important. Get informed consent. It's a neglected but an urgent clinical need, and I'll tell you a lot about it. In fact, look at the resources on the right. Other people have done the work. So benzodiazepine information contract. It's actually quite important. You may want to actually grab a copy of it and as a group examine it, because all it has in it is good information. Things like, these are the risks, these are the benefits. You will not take benzo from other folks. We will work together if it's appropriate to taper the medication down. It's good education. It alerts the clinician, alerts the patient that this is a serious medication and we're taking it seriously. So please consider grabbing these PDFs and check it out for yourself. So as I just said, these contracts really matter. It helps educate patient, helps educate a patient support system. It preemptively educates a patient. That's really important. Education is power. It lays out the parameters that we're going to set between you and I, dear patient, on how we'll prescribe the medication. Shared responsibility model is now activated, and it helps the clinician execute their fiduciary duty. It is a fiduciary duty to educate our patients, because we have a responsibility not just to be prescribers, but to be educators who also prescribe. And this, of course, without a doubt, will lead to fewer and fewer people being harmed by benzodiazepines and more people being helped by either short-term or, if necessary, long-term use of benzodiazepines. Let's talk about deprescribing, and I have so much good information for you here. If the situation is right, deprescribing is important. It should be planned and supervised. It should not be, I went to a lecture, I read an article, benzos are bad, we're going to stop you, okay? You got 2 weeks to stop it. That is not appropriate. Planned and supervised process is the way to go. And motivational interviewing is by far the best way to execute it. So why consider deprescribing? Well, the patient may no longer need it, but the patient may not know they don't need it. And also, withdrawal. What if the patient has actually run out of the medication before and had rebound anxiety? They may assume the rebound anxiety is nothing but their anxiety come back, right? So that could be a problem. The patient may have misperceptions. You may have to, and I may have to educate the patient about, we're going to do it step at a time. And we're not going to hurry it. If this happens, we'll do this. If that happens, we'll do this. But together, we will get to the other side. That is creating a bond with the patient. That is using motivational interviewing to help our patients. How do you start the process of deprescribing? 4-step process. Number 1, engage the patient directly. Tell them what your concerns are. It's also okay, and I've done this with patients, to say 20 years ago, I didn't know what I know now. 20 years ago, I said, nothing to worry about. Today, I'm willing to change my mind. It's humble. It's an appropriate approach to take. So yes, please consider engaging the patient. Listen, don't tell them. Listen, have a dialogue. Number 2, might as well start this at the very beginning or as soon as you can. If the patient comes into you transferred from another clinician, that's a good opportunity to start the conversation. Raise awareness. They may not know that there's even a potential problem. How are they to know? And then, of course, 4 is reassurance, gradual taper, and willingness to be flexible are the 4 elements of deprescribing conversation regarding benzodiazepines. We are also very fortunate that the state of Pennsylvania, or as they call it, the Commonwealth of Pennsylvania, is so concerned about this issue, they've created a set of 14 recommendations that are outstanding. You may want to print this out. I've given you the link there and look at it because they're just so good. But let me offer you very quickly what those 14 steps are. Number 1, as we've talked about, before you start benzos, educate. Understand the patient fully. Strengths, weaknesses, needs, short-term plan, long-term plan. Be willing to modify them, but don't be blind walking into the process. Step 2, if there's a substance abuse history already, please be careful. Doesn't mean don't do it, just be careful. Number 3, document. Remember that informed consent I talked about? If you don't want to do that, that's okay, but document some other way. Number 4, a contract really does help. It helps the patient, it helps you, it helps the system. It's just a terrific thing. Why would you not want to do that? 5, again, one more time, the prescription drug monitoring program. Texas has one. Every state, I believe, has one. Let's use it. In fact, we're required to use it. Step 6, you may want to limit the number of tablets and really limit the number of refills. That seems to help. Not to say we want to make a patient's life difficult, but it's okay to be highly controlling of how you give the medication. Okay, number 7, if you're going to use a drug, try not to use the super short acting drugs unless the patient has only needs for situational anxiety control. It's probably better to use an intermediate half-life medication with a benzodiazepine class. But again, remember, we have to really customize it to the patient's need. Then we go after step 8, which is patients deserve relief and need relief and demand relief very quickly, but it doesn't mean the dose that got them the immediate relief is going to be the correct dose long term. It could be a lower dose. And by the way, after 2 weeks, 4 weeks, they may be more able to participate in psychotherapy or self-management or sleep hygiene or whatever. So don't just think, now that benzos have helped them, let's continue benzos. There's simply no other way to get them better. That is not the case. By the way, step 9, if you're using it for acute grief, careful. Short term, if you're using it for insomnia, careful. Does not mean automatically say no. It just means very careful. Step 10, caution should be used in the elderly, but it's not a denial. It's just caution. Obviously, pregnancy, lactation, which is step 11. And then step 12, just remember, it can in some people, not always, but it can in chronic use worsen depression, worsen impulse control, and definitely worsen hypoxia associated with multiple sleep difficulties. So all those cautions have to be kept in mind. Number 13, what if they are intolerant to other drugs? Well, then long-term use of this class of medications may in fact be necessary in some patients. Careful patient selection is important. Step 14, never ever ignore the black box warnings. Pay respect to it. Black box warnings, however, are not contraindications. They are just warnings. So keep all that in mind. But there's no need for us to practice therapeutic nihilism, which means, it'll always go bad. That is grossly inappropriate. To assume just because you started 10 patients on benzodiazepines this year, all 10 ultimately will develop problems, and therefore there will be no 11th patient who will ever get benzodiazepines from my hands, is therapeutic nihilism. Not appropriate by thoughtful, caring clinicians. So I've offered you an algorithm that comes to us from the Canadian Family Physician Journal. It's excellent. It's pretty much what we talked about, but it's just putting all that in this slide and the next slide that you are welcome to access in just a very nice tabular format. And if you are a first-year resident, you need to know this. If you're a full professor and you've been doing this for 30 years, you and I need to know this. This is not an issue of only a beginner challenge or a very practiced clinician challenge. We're all really in this issue. So the same article offers suggestions on if a patient does need a benzo or a Z drug for insomnia specifically. How do we minimize the risk? How do we optimize outcomes? I won't go into in detail just because of time, but you should come back to it and visit. There are medications you can use to potentially help come off benzos. The ones that I've had the greatest success with, and so the data reports is things like carbamazepine. If it's appropriate, it could be things like propranolol if the patient is prone to somatic symptoms. It could be clonidine. Clonidine, as you know, is a alpha 2A agonist. It can suppress withdrawal symptoms from benzodiazepines. What it won't do is prevent seizures, though. So if you're concerned about seizures, then you're probably better off using an anticonvulsant to help the patient come off it. But there are ways. Neurontin has been helpful. Lyrica, pregabalin has been helpful. So keep those options in mind if you're using them to cross-taper the patient. Okay, so here you are. Carbamazepine, valproate, pregabalin actually, in fact, do have good data. So does gabapentin. And gabapentin tends to be relatively inexpensive medication that a patient could use if they're trying to slowly come off a benzodiazepine. So there might be situations where switching to a longer half-life benzo is appropriate. In fact, in UK, in United Kingdom, they routinely switch patients to diazepam. Diazepam, as you know, has a very long half-life. Americans, we tend not to do that. We tend to use the drug they're already on and use that to cut the dose down. Either approach is perfectly fine, as long as, generally speaking, our goal is to bring the dosing down. I've got some good advice on half-lives and dose equivalency to 5 milligrams of diazepam. If I was you, save this presentation and this slide deck so that you can just refer to it at your leisure. It is also very important to differentiate between dependence and addiction. They're very different things. They're very different things. Dependence is dependence, which is I have physiologic dependence, but addiction is quite different. As you know from DSM criteria, addiction is not just dependence, it's more than that. So if a patient says, every time I've come off it, I get my chest beats faster, I don't sleep well, I get shaky, and you go, he's addicted to whatever, Xanax or clonazepam. Be careful, that's not correct. They are dependent on it. They may or may not be addicted. You will have to do a further assessment to determine that, okay? There are some situations where you want to do a rapid discontinuation. A patient's pregnant, just had a suicide attempt, whatever. But if you can, that's not ideal. Rapid withdrawal from benzos leads to not only a lot of suffering for the patient, they can often fire us and move away and get into even more trouble. So a rapid withdrawal is sometimes appropriate, but not always. It's best to do it this way. Slow is good. Slow is really good. What is slow? Well, slow is about 10% a week, which is, how do you do it? If you're on 4 milligrams of Xanax, how do you do that? Well, get closest to it if possible. And sometimes even slower is perfectly appropriate. Perfectly appropriate. If it takes you 4 weeks to go down by 10% or so, who cares? Who cares? Especially if the patient's not currently in major challenge with it. Why not take your own sweet time, especially knowing that the GABA system is quite oversensitive to change. So I guess the take-home message is the direction at which you move, which is in the direction of tapering, that's more important than the rate at which you are tapering in most cases. Z drugs can be very difficult to come off, sometimes more difficult than benzodiazepines. I do want to caution you. Difficult. So getting a patient to break it into fragments and just tell them, hey, it's okay for you to just cut off the tiniest bit. Psychologically, that helps, but also physiologically, that gentle taper off is perfectly fine. Please do consider doing any of these 4 steps, either in combination or by themselves with Z drugs. Z drugs, let me assure you, are not that easy to help patients come off. So safety measures, make sure you titrate, observe more often, let them contact you more often, and obviously patient education of not just the patient, but sometimes the spouse, the children of, or the parents